Welcome back to Ellie Scrubs In. In this video, we'll walk through the surgical creation of an arteriovenous, AV, fistula, the gold standard for long-term hemodialysis access. We'll focus on the radiocephalic AV fistula, the most common type, created between the cephalic vein and radial artery at the wrist. Step 1. Preoperative setup and patient positioning. The patient is placed supine, with the arm extended on an arm board and the wrist slightly dorsiflexed. Local anesthesia or regional block is often sufficient, though general anesthesia may be used in selected cases. The surgical field is prepped and draped in a sterile fashion, with vascular ultrasound available for vein mapping if needed. Step 2. Vessel identification and dissection. A longitudinal or curvilinear incision is made over the volar forearm, just proximal to the wrist crease. Using Metzenbaum scissors and fine-tip forceps, the cephalic vein and radial artery are carefully dissected free from surrounding tissue over 3 to 5 centimeters. Vessel loops are placed for control. Care is taken to handle the vein gently to avoid injury to branches of the superficial radial nerve, preserve the vasa vasorum for both vessels, and to avoid spasm or intimal injury. Pearl. Irrigating the vein with heparinized saline can help assess size and distensibility. Step 3. Vessel preparation and clamping. The radial artery and cephalic vein are both clamped proximally and distally using fine vascular clamps or vessel loops. The end of the cephalic vein is spatulated, meaning a small slit is made along its length to create a wider, oval-shaped opening. This helps prevent narrowing and ensures a wide, tension-free anastomosis. Next, a small incision is made into the side of the radial artery using an 11 blade, and the opening is carefully extended with pot scissors to match the size of the vein opening. Pearl. The artery and vein openings should be closely matched in diameter to promote good flow and reduce the risk of anastomotic stricture or turbulence. Step 4. Anastomosis. A side-to-end anastomosis is performed using 6-0 or 7-0 polypropylene suture. The back wall is sutured first, using running or interrupted technique, followed by the front wall. Before completing the final few sutures, the vessel is flushed with heparinized saline to evacuate air and debris. Once complete, clamps are released and flow is assessed. Step 5. Flow assessment and closure. A palpable thrill or an audible bruit confirms patency. The anastomosis is inspected for bleeding, and minor bleeding is controlled with pressure or fine sutures. The wound is irrigated and closed in layers, typically with absorbable sutures for subcutaneous tissue and non-absorbable suture for skin. A sterile dressing is applied. Postoperative care and follow-up. After the procedure, the arm is kept elevated and monitored closely for signs of bleeding, hematoma, compartment syndrome, distal ischemia, and thrombosis or lack of thrill. The dressing should be kept clean and dry, and tight bandages are avoided to prevent compressing the new fistula. Patients are instructed to avoid venipuncture or blood pressure cuffs on the operative arm and to gently exercise the hand and forearm to encourage flow and maturation. Fistulas typically require 4 to 8 weeks to mature, and follow-up includes physical exam and possibly ultrasound flow studies to assess patency before the first dialysis use. Final thoughts. AV fistulas are preferred over grafts and catheters due to lower infection rates, better long-term patency, and fewer interventions. Early fistula maturation takes 4 to 8 weeks, so timely referral and skilled surgical technique are key to success. Thanks for scrubbing in today. Subscribe to Ellie Scrubs In for more concise surgical walkthroughs, and check out our vascular and general surgery videos for more.